Hi, everyone. Welcome to our weekly webinar on preventing and managing COVID-19 in the workplace. This is Karen O'Hara. I'm the Director of Marketing and Communications with WorkCare. This is our 34th consecutive week of presenting the webinar. If you're a regular attendee, we're happy to have you back. And if you're just joining us for the first time, I think you'll find it very informative. Those of you who are accustomed to participating every week know that we post the recording on our YouTube channel, and we publish questions and answers weekly on our website, and we reserve time for questions at the conclusion of the formal presentation. Answer all the questions, including those that are not we're not able to get to in the time we have allowed. During the session, please submit your questions using the Q&A function in Zoom. The webinar typically lasts about 40 minutes. Our presenter is Anthony Harris, MD, MBA, MPH. Dr. Harris is board certified in occupational medicine. He's WorkCare's Chief Innovation Officer and Associate Medical Director for on-site clinical operations. He's also our lead clinician for WorkCare's COVID-19 response. Now I'll turn it over to him. Thanks again for joining us.
Excellent. Thank you, Karen. Thanks, everyone, for joining us once again. Happy to be talking to you this week during our week of the election. I know a lot of you are probably fatigued from the election, and obviously a lot of us are fatigued from COVID operations. So we're going to keep today light and hopefully bring you up to speed on some diagnostic testing. And we're also going to touch on obviously some epidemiology and look at and examine the impact as we move forward that we'll be dealing with regardless of who's president come later today, tomorrow, or whenever, right? So without further ado, we're going to move forward with our format that you all are familiar with at this point. The clinical update first, followed by pathology, epidemiology, then prevention. And then we'll talk about workforce strategy again briefly today with regard to what WorkCare does as we move forward with testing. So our clinical presentation we want to highlight today is a bit zoomed out from what we typically present on. And what I mean by that is that we're going to examine a look at the impact from a susceptibility and presentation of cases in a number of states. All right, so obviously we're spiking at this point. Everyone is clear and on the same page about that. But we want to look at and start to examine what is the possible cause of those spikes. Now, we won't be able to answer these questions all today, right? But we want to begin to ask questions that help us get at those answers so that we can understand more fully how to protect our workforce in various scenarios, various cases. So let's look at Illinois as a case of how COVID has presented clinically amongst the population. This particular graphic comes from CDC as well as Georgia Tech. And this research is examining several factors. First, we're going to look at the presence of shelter-in-place orders on this particular time scale. You see that at the bottom there in the green and red bar there. And that's the period in which shelter-in-place orders were present in Illinois. The cases now that we're looking at are highlighted in gray. So those individual histogram bars are the cases that have happened over time. And so you can first off see that the cases spiked early. The shelter-in-place orders became effective and decreased the cases back in the summer. And when those orders were relaxed, you see the cases now escalating to where they are today, all right? And when we start to examine and ask questions about why this may be in Illinois, we can look at then the population and their mobility in the state as a factor of transmission. we talked about the R factor, R naught factor, right, which is predicated on the number of contacts that individual that is affected by COVID may have. That number being 2.5 to 3 in most cases, and in some cities at as high as 5, right? So let's look at then the mobility of individuals, how they move, and how they're out and about in states as we see these spikes. So the numbers on the right-hand side are representative of the decrease in individuals in the population present in those particular settings. So the workplace in Illinois is down in terms of people being present by 33%. And if we look at that, look over the histogram overlay of data, we see how those data points have changed over time. And obviously, during shelter in place, workplace was impacted more fully, and the number of people not showing up to work or kept home. And we can see then going back to the right what that looked like for the retail sector, what it looked like for transit stations, and then the percentages of people at home. Finally, the mobility index is a composite index looking at again, number of people that are out and about in general. And we won't get into the nitty gritty of how that index is derived from Georgia Tech. But what we want to examine then is how does this look from state to state as we're seeing spikes in different states? So let's go to another example here. Let's look at California. California obviously being hard hit early on, but as you look at this histogram here, it's not seeing the same spikes that are present and that we saw in Illinois. Again, going back to Illinois, at the 300 level there for 7-day change in incidence. If we look at where California is today, far under, they're under the 100 mark here, right? And if we look at their shelter-in-place orders, roughly overlapping that of Illinois, we see the cases that spiked in the summer and now have somewhat spiked, but again, nothing like we're seeing in Illinois in the Midwest. And if we look at then the metrics with regard to mobility, the 38% compared to Illinois, 33% down in presence of in the workplace, individuals in the workplace. Retail a lot lower, right? If we look at Illinois again, retail was only down in presence 18%, 25% in California. Transit down 38%, 32% at home, a little higher than Illinois. The mobility index still 3.8. Let's go to another one, New York. What do we see here? We're seeing high spikes early on in COVID, right? We all knew New York was a hot spot, but we see that dramatic drop after the shelter-in-place orders had their effectiveness at reducing transmissions, and the numbers just haven't spiked again in New York. It's to the levels that we see in Illinois and other places, right? If we look at our metrics again on the right, 34% down in the workplace, 20% followed by 33% in transit. At home, 35%, again, higher than the other two states here that we looked at, and mobility index a little lower in this case, 33.5. And so flipping to Wisconsin, right? We see they're off the charts in terms of impact. And let's look at then their period of shelter in place, roughly overlaps the period that we saw in other states. And we see the histogram here, dramatic increase. And we see in the workplace that they had lower percentages of people that were not out, that were staying in place, basically, right? So down only 27% from a norm that would be present in the workplace. 16% lower than the other states, 16% in from a retail standpoint, 16% in transit, a lower percentage people staying at home. The mobility index higher in this case, meaning people were more out and about, right? So clearly we see an association here of what can happen when we're talking about people out and about and social distancing importance and trying to understand what is the risk for your workers in a particular community and why. We're starting to understand and ask the right questions, right? But we sometimes get thrown a wrench, right? When we look at Idaho, we see low cases, a spike, and then another spike. And as we trace the overlay here of our metrics, do those spikes follow what we see from a mobility standpoint? And it's not as clear cut, right? In this case, we see clearly in Idaho, though, the other trend that we saw in Wisconsin is that there are fewer people that were staying home, right? In this case, the percentage of workplace presenteeism decrease in this case was not as drastic as we saw in other states. Mobility index is higher here, 3.8, right? So again, there's a clear association of the mobility of folk and the transmission of COVID in states and how they were affected. And so from a clinical transmission standpoint, it all makes sense, right? And that's why we continue to be impacted the way we are in the different states. And frankly, at this point, right, does it make sense to bring your workforce back if you're not doing those preventative measures of some type of diagnostic or screening testing? And our suggestion would be, yeah, those considerations aren't in play unless you should not be in play of bringing people back unless you have those means to help keep those workers safe. Again, we're talking about the workforce that can work remotely, not the essential workers, critical essential workers that have to show up still. So let's look at then our update from a pathology standpoint. We'll get down into the nitty gritty of genetic mutations. We've talked about this twice now before. We want to give an update to the impact of genetic mutation of SARS-CoV-2. Is it still mutating? Are those mutations relevant to the impact that we're seeing from a COVID standpoint? Yes or no? So let's remind everybody the anatomy of SARS-CoV-2. We look at the spike protein in particular, right? That's what we want to highlight. The protein that determines how the organism gets in, the virus gets into our cells, is the spike protein. There are other proteins that are important for detection of SARS-CoV-2, particularly some of the membrane proteins, the nucleic acid, in this case capsid, and the envelope protein. So all these proteins are important because there are diagnostic tests that are designed to detect these particular proteins one way or the other, all right? And so when we look at then some of the studies that have examined genetic mutation, in this case, we'll focus in on the spike protein as we have before, because that is one of the major proteins that are important both for detection as well as immunity from a vaccination standpoint as well. And if we look at mutations of that protein, we know that it's mutated. We talked about those mutations before months ago as the virus was transmitted from Wuhan, China to the US and abroad. But one of the major mutations that we want to examine in this case is the predominant mutation for the vast majority of presentation, not just in the US, but globally, okay? And that's the D614G mutation, all right? And we'll get into, let's look at that a little bit more in depth. So what is this mutation? The D614 versus the G614 is related to the spike protein, all right? And the supposition early on was, why are we seeing a greater presence of the G614 mutation at this point in time in the general population? And the supposition behind that is that it became more, it made the virus more infectious, all right? And we see that actually play out in again, around February of this year, the shift from the D614 mutation to the G614 mutation in the spike protein, right? And studies have looked at then what is the impact, right? We know that we see this more in the populace, and we know that then this mutation has likely caused the virus to become more infectious. But are there other considerations that we need to keep in mind? This particular research coming from Cell publication back in August helped answer some of these questions here for us. And the first question was, is it making the outbreak harder to control? The answer to that is yes, right? This mutation has increased the infectiousness of the virus. The next question is it making the virus more virulent towards clinical presentation, right? Does it worsen the severity of the clinical presentation? The answer to this question actually is no. So even though the virus has become more infectious, it is not making people sicker, so to speak, in terms of severity of presentation. And then lastly, the therapeutic vaccination ability to provide immunity from vaccination, is that affected by this mutation? And the answer is actually a little bit of both, right? Yes and no. In the case of the specific spike protein mutation, it does not affect the body's ability to recognize SARS-CoV-2 as foreign from a clearance standpoint, but it does affect potentially a vaccination approach from a genetic drift and a genetic shift standpoint. And we talked about those two key terminologies, genetic drift and genetic shifts, as the flu virus does also, right? And so what are other experts saying in this regard? David Montefiore is a virologist at Duke University, a leading virologist, and he sums it up for us pretty clearly here as they study the shifts of mutations and drifts of mutation of SARS-CoV-2. It increases the effective infectiousness. We know this. There's no change in clinical severity. Again, we're seeing this play out. And the resistance to antibody neutralization actually is weakened by this mutation. So our ability to clear the virus by our antibodies is improved due to this mutation that only gave the virus an advantage from a spread standpoint. And in terms of resistance, that is decreased, which is a positive. And then genetic drift will still likely affect a vaccine's efficacy year to year, as we see with flu vaccines. So again, we're dealing with COVID very likely in perpetuity, at least for the next 5 years. Everyone has agreed, if not for longer, if not permanent, right? And we'll have to have vaccines that are continually updated for that particular year's strain of SARS-CoV-2. So now let's look at our numbers here from an epidemiology standpoint, where we stood last week: 8.6 million cases in the US, 21.2 cases per 100,000 individuals. We've increased now to 9.2 million cases and 25.4 cases per 100,000 individuals. Looking at the Dakotas, the Midwest, hardest hit, obviously the coasts have cooled off. They're still, again, seeing increases, but nothing close to what we're seeing in the Midwest here. If we look at deaths, we were at at the point we were at 8.6 million cases. We had 0.2 deaths per 100,000. Now we're up to 0.3 deaths per 100,000 here. And so we'll continue to look at the deaths from a national standpoint. If we go global now to look at cases, confirmed cases of COVID, this is where we stood a couple weeks ago in comparison to some of our neighbors, India. This is where we were 2 weeks ago and where we are today for confirmed new cases. So on a daily average, right? 7-day rolling average. So again, we are leading the way here when it comes to total new confirmed cases. If we look at then per million individuals though, France is where we focused in on last week and their impact, and then United Kingdom followed France. Obviously, they quarantined, had a curfew in place, had a shelter in place rule come out last week, and this is why. And then if we look at today, they're still in that same situation in terms of increasing cases per million, far greater than we are here in the US. Let's jump to deaths. So 2 weeks ago, we were looking at kind of neck and neck with India in terms of 7-day rolling average of deaths. If we fast forward to last week, we see where we stood in comparison to India. And now this week, it's a dramatic change in terms of new confirmed deaths from COVID compared to India. So what's happening there, right? Why are we seeing this divergence now from our neighbors? We do see increases in France, we do see increases in the United Kingdom, but again, they're not at the same level as we are when it comes to total number of deaths. If we break that down per million, however, now we see that France and the United Kingdom are moving towards us in terms of the rate of deaths per million in the population. All right, that's where they stood a week ago. Is where they stand now. Still, they've exceeded where we've been in terms of per million now, and why we're seeing dramatic lockdowns, if you would, in France and the United Kingdom. Total number of tests, we always like to look at this metric because we want to see this metric improving in terms of being able to test more and more folks in the population. India and the US are testing more than anyone else, right? In terms of total number, this is where we stood a couple weeks ago, where we stand today now. And then when we break this number down per 1,000 people, we can see that the United Kingdom and France actually are testing more per capita than the United States, and then far more than India, right? And so hopefully this number will increase in the US here as we get greater and greater access to diagnostic testing, again, which is the focus of today's talk here. And then if we look at where we are today, again, no movement in reference to United Kingdom and France as opposed to the US. Total number of or percentage of positive cases for our testing, we see this metric, we've seen this metric go up. Again, that's the wrong direction for this particular metric. We want this metric to go down. This helps us understand the accuracy to which we're looking at the prevalence of COVID in the US. And this continues to go up week by week, where we were 2 weeks ago, where we were a week ago, and now where we are today. Again, still seeing an upward trend of positive cases percentages wise for the US. And again, we're seeing that in France and the United Kingdom. That means the disease is far more prevalent than what we're understanding at this point. And so we got a lot of work to do, right? If we talk about now prevention, let's get into the diagnostic testing update here. We obviously won't be able to cover every diagnostic test that's out there. We presented last week, there's over 200 tests that have been approved by the FDA for emergency use authorization, right? What we want to be able to do, though, is articulate the different types of tests, why they're important, how they fit into your testing regimen, and then finally, we'll talk about what WorkCare can provide as a partner with our operations here. So what, first and foremost, does the CDC say about testing? Who needs to get tested? I know this has vacillated over time. It's thoroughly confused all of us, right, in terms of their recommendations in the past. So let's just quickly look at what they're saying currently on testing. Who should get tested? People who have symptoms, clear cut, right? Boom, there it is. If you have symptoms, go get tested, is what they're saying. If you've had an exposure being 6 feet for 15 minutes, and we know, again, we're gonna articulate that 15 minutes as a cumulative, right, exposure from someone with confirmed COVID-19, you need to get tested, right? And then if you've been asked to get tested by a clinician, then they're saying, yes, go ahead and get tested and follow the advice of that healthcare provider. All right, so we're clear now, up to speed on what CDC is saying. Now let's look at then testing in the US in terms of where we're at, right? And where we're at from a positivity standpoint, and what states are doing some of the heaviest testing, right? So when we talk about the US spread of testing, heavy lifting, California, Texas, Florida, and New York, right? They're doing the most tests, well over, the 15 to almost 20 million tests is where they're at. Obviously, some of the most populous states here in the US. What we're able to do and what we recommend is going to the CDC website and drilling in on those cities and those states, obviously, and cities in which your populations are located for your facilities. And we want you to continue to get the relevant data around prevalence. And we want you to understand, as we've built in regards to your testing recommendations, the different levels of incidence, right? So if you haven't done that yet, we're going to urge you to do that. If you need help with that, let us know. We can help in that regard as well. And if we look at our approach and then try to understand some of the tests that are out there and some of the tests that we want to highlight, point of care testing is becoming the kind of go-to for testing because of the speed of rapid tests at the point of care, okay? And if we look at an example of a point of care test that is being used widely at this point, not just by the federal government that has sequestered many of these tests to the order of millions, but also in industry such as the TV and media industry, the NFL, etc. Right? Quidel Sofia is a rapid point of care test that comes as a FDA waived test. All right, FDA CLIA waived test means that it's low complexity enough that you don't need a huge facility that is CLIA certified to do medium and high complexity tests. All right. So this is something that is very amenable to point of care for a facility that has enough critical mass, if you would, to do the ROI piece of this type of testing. And we can get into the ROI at another point, but we want to present now examples of these type of tests because they have positives and they have negatives, right? And we want to discuss these. In this case, the sensitivity and specificity of this particular test is pretty decent, right? If we look at SARS-CoV-2, the sensitivity for the Quidel test is 95.2%. If we look at specificity, it's 100%. Now, this 95.2 and 100% sensitivity and specificity is from contrived tests, okay? We've talked about that before, but as a refresher, contrived tests mean that this manufacturer, when they were trying to examine their sensitivity and specificity, spiked some samples with SARS-CoV-2, and they spiked them to the order of sometimes 2 to 5 times the normal amount that we would see in a clinical sample, all right? And that is normal process. That is not specific to a manufacturer, but that's how these tests report their sensitivity and specificity typically, all right? So just keep that in mind. One of the things that we want to point out, as we're pointing out in this case, is that now there are tests that can do dual testing, both for flu, since we're in flu season here, and as well as SARS-CoV-2. So let's look at the sensitivity of detecting the flu. It's a little bit lower in some cases than SARS-CoV-2, from 90 to 97%, 89 to 90% sensitive. Specificity, 95 to 94, 96 and 97, all right? So the advantage, obviously, of doing a dual test like this allows us to quickly identify who has SARS potentially, who doesn't, and who has the flu and who doesn't, so that we can keep people and get people back to work quickly versus having to be out longer because we haven't differentiated between SARS and the flu, okay? If we look at then some critiques of this type of device, a researcher that is, his name is Dr. Harris, actually, but he's a researcher, University of Arizona, and they looked at and have been doing tests with Quidel to the tune of 2,500 people since June, okay, and between June and August. And they looked at, in particular, the performance of Quidel as it compared to PCR. And they reported 54 individuals were missed by the Quidel test, right? And we're bringing this up to speak not just to the sensitivity specificity, but some of the nuances when it comes to testing and how these tests actually play out in regards to their performance, okay? The other thing we want to highlight then is another sample, 1,500 randomly selected individuals that had no symptoms. 19 of them tested positive by PCR, only 6 by Sofia. So what's the deal with that, right? Does that mean this test is not as good as it's purported to be? Or are there other factors that play into whether or not the test detects what we're looking for, obviously in this case, SARS-CoV-2. So asymptomatic individuals is a consideration for testing, right? Those individuals who are asymptomatic are thought to have lower viral counts, and lower viral counts may have a lower likelihood of being detected by diagnostic tests that are out there, right? The hundreds of tests that are out there. When we talk about PCR in particular, PCR also detects inactive virus. We know this. We've talked about those individuals who continue to test positive for weeks, in some cases months, after their period of infectiousness has expired, right? On the 10-day, 14-day period. And that virus is inactive, but it still will be detected by PCR. The advantage of this type of test, the Quidel, is that those individuals don't come back positive for this particular test, right? And so that's a consideration as well. And then also the very low viral counts that individuals may have that are asymptomatic and sometimes even post-symptomatic may not be detected as well. And those individuals are thought likely not to be infectious. Okay, so these considerations are known, and these considerations should be a part of evaluating who can return safely from work, even when testing is involved, right? And so that's why we want to have our algorithm, if you would, in the forefront of these type of testing regimens. So when we talk about the different types of tests that we want to be cognizant of, there are more out there than we need to drill in on. And so what we'll do is highlight then several tests that are important to us and kind of give an update as to their utilization. So real-time PCR is by far and away one of the methodologies that is widespread, okay? This data, again, we've presented before, this body of work from Harvard. I put the link down at the bottom so you can access it directly here after the presentation. But real-time PCR amplifies the viral nucleic acids, and we're able to detect both active and inactive virus in individuals. Still the gold standard globally for detection of SARS-CoV-2. Isothermal amplification is an example of a method for detecting nucleic acid without having to do what's called thermal cycling. So this is better appropriate for a point of care utilization, all right? The Abbott systems utilize this methodology, and it is becoming more effective for point of care. And we'll see most likely this approach play out over and over with manufacturers as we move forward for detecting large number of positives quickly, all right? And then if we talk about the other methods that detect proteins, not nucleic acids, the one we really want to zero in on is viral antigen tests, right? That's the Quidel that we presented, where we're using captured antibodies. The little picture there to the right of this highlighted test number 3, it depicts an antibody capturing an antigen, and the antigen being, again, a protein, piece of protein from the virus itself, whether it's the spike protein or whether it's some of the capsule proteins. We can detect through this methodology someone who is infected by SARS-CoV-2, all right? So those are the technologies that are still in play, right? Those are the technologies that they've been around now since the beginning of COVID, and we haven't really seen the emergence of anything novel that has displaced any of these technologies at this point. Are there some out there? Absolutely. Have they become approved and ubiquitous enough that we're seeing them really being effective when we're talking about diagnostically either screening or diagnostically testing individuals? And the answer to that is not yet. So we'll keep an eye out for those emerging technologies. One thing we wanted to bring back to the forefront again is the importance of looking at the accuracy of your tests, right? Obviously, it's intuitive that we want to have higher sensitivity and specificity in our diagnostic tests. But again, the reason why behind that and how it impacts our ability to understand who's positive or who's likely to be positive, even if they have a negative result, is important, right? And it's predicated on, if you look at the bottom of this chart, it's called Pretest Probability. That essentially is speaking to the prevalence of SARS-CoV-2 or any disease to that point in the community. So the higher the incidence in the community, the higher the probability someone is positive for a particular illness. And again, in this case, SARS-CoV-2. So if we have, let's say, 20% prevalence in this case, right, for a pretest probability, we want to have in the green tracing there the ideal scenario of having a high sensitivity and specificity, 90 and 95. Because at that level, right, of prevalence, we still can detect with a negative result someone and clear them, someone who has tested negative below 5% cutoff, right? So that dotted line you're seeing across there is a cutoff of clearing someone to return to work, right? You're not infected, you don't have the disease, you're clear to go back to work. And if it's above 5%, that's an uncertainty that we're not comfortable with in the general clinical community of clearing someone from disease or being disease-free, okay? So now let's look what happens if we drop the sensitivity to 70%. Let's keep specificity at 95, drop sensitivity to 70%, and now at 20% prevalence in the community, pretest probability, that individual who gets a negative test, the blue tracing there, has a greater than 5% chance of still having the disease, okay? And so that's why it's important that we want to look both at specificity, but also, more importantly, sensitivity for a particular illness. And if we are getting this data, right, from the PCRs that are happening in the communities, then we can more accurately and more quickly clear people to return to work because we're confident about the result of their particular test. Now, are there other nuances around the accuracy of tests, user error when you're collecting and things of that nature? Absolutely. But when we're talking about the tests being utilized, that's what we want to make sure we're nailing down as much as possible. Now, the lists of approved tests, like I said, they're extensive. I've presented this data before, and it has just lengthened in terms of the presentation of sensitivity and specificities for the various tests. Again, I put the link here. You have access to all this data, and you can utilize it so that you can understand what tests your folks are likely getting in their community and try to understand the sensitivity and specificity as we make clinical judgments about return to work. All right, and again, we won't obviously go through each one of these due to time here. But when we talk about then our approach at WorkCare, what have we chosen to do? How have we chosen to help our clients when we're talking about practical testing approaches, right? Last week, we spoke to taking data that we collect on workers, in this case, using social distancing or physical distancing technology, and translating that data into now information that allows us to segment more effectively our workforce that's at risk for having close contact, for having a potential exposure, right, as a practical means for testing. And so when we talk about the application of our testing tools at WorkCare, here's what we're using, just so you can kind of contrast with what you have access to or contrast with what you may be interested in utilizing in your facility. The first one, Carestart, as a point of care test. It uses lateral flow chromatography, all right? It uses that methodology I spoke to and presented here with captured antibodies that is basically like a pregnancy test, right? So we're allowed, we have the ability to take a sample quickly, introduce that sample to the chromatography paper, and we'll see a result in 10 minutes if that individual is positive or negative, right? And so it's a quick way in the point of care to provide reliable results for a workforce. Now, again, scaling this with these swabs is not terrible because there's not a lot of equipment and things of that nature. But again, it's something that we'll see more of get approved here in the U.S. Because the accuracy, sensitivity, and specificity of these tests has improved dramatically. If we look at then another example of what we've chosen to deploy, saliva samples is a very effective way, easy to collect, right? You spit into a tube, and the sensitivity and specificity is very high for our partner, in this case, OneHealth, allows us to nationwide deploy saliva samples and collect them through overnight mailing, FedEx, if you would. And the results are posted within 48 hours, right? And so again, easy, scalable solution that in this case looks for the nucleic acid in the saliva through PCR, again, the gold standard still for diagnostic testing. And then finally, point of care assays. We are using the Sofia 2 device. We've been very successful at deploying this and have seen a good response from the employees who are able to get their results in as little as 15 minutes, right? In terms of peace of mind, obviously that's important, but for your surveillance programs, doing this on site is still a scalable solution for a workforce. And there is an ROI factor to it, obviously, for the number of individuals you need to test, but we can talk about those on an individual basis. And so we're excited to deploy this technology. We're excited to have a combination of flu and SARS ability with the Sofia device, and we want you to consider, no matter whether it's this or other solutions that provide the same capability, consider doing both, right? Knowledge is the old colloquialism, knowledge is power, right? In this case, knowledge means, in terms of diagnostic wise, we can keep the workforce in place and get them back to work sooner because we differentiated between COVID and flu. So with that, we'll go ahead and start the question period. Thank you so much.
Thanks, Dr. Harris. That was a great update on the testing and makes you realize how overwhelming it can be if you're trying to evaluate your choices. So one person had asked about the source, so they could see from that slide where you popped up all the different tests. They're available on the FDA website.
You say that one more time. I missed the last part of that. I apologize.
Are all those tests that you showed in that one slide where you popped up the whole list, that's on the FDA website?
No, so that list is actually on a Harvard website, and here, I'll go back to that slide so you can see at the bottom of that slide here. So the link is right there at the bottom of this slide. So I'll point it out on the laser pointer. So go to this link,
great.
take you right to that list so that you guys have access to it. The FDA, unfortunately, does not have all the data on the accuracy. I wish they did, and I wish they required that and posted it for the diagnostic test. They don't. But Harvard has done a good job of distilling a great number of them. It's not complete, and it's not updated. The last update was November 1st, so it's not updated on a daily basis, but it is, at this point, one of the best resources that we've seen.
Okay, yeah, it certainly beats trying to go to each vendor and read their statistics and findings by individual websites.
Absolutely.
Here's a question about screening. If an employee has to take other employees' temperatures for screening of presumably healthy people, and they are only in close contact for about 5 seconds, do they still have to follow the guidance for wearing gloves, gown, and N95? Is that really necessary? This level of PPE is not recommended for other close contact situations unless it's over a 15-minute period. What puts temperature takers at higher risk?
Sure. So with temperature takers, we essentially treat them like healthcare workers in regards to continuous exposure to individuals that may be infected, right? And as a result, right, if you are a temperature screener and you're in close contact with individuals successively, you are likely to go over your exposure limit, in this case, that 15 minutes within 6 feet, right? And if you're in that scenario, you should be wearing appropriate PPE to prevent a potential transmission. That's how we've done it with healthcare workers, and that's how we've done it with our workforce on site that have deployed temperature screeners. And we've done that to the tune of over 300 sites at this point with WorkCare. So the Flip side of that is if you're a temperature screener and you have the ability to screen someone further from greater than that 6 feet distance, then those PPE items are not essential. But again, it's all predicated on the potential for exposure.
Okay, a couple questions about testing regarding the Sofia Carestart methodology. Does that need to be administered by a clinical professional, or can someone who's not a clinician be trained to utilize that type of point-of-care testing?
Sure. So it still needs to be administered by a clinical operation. And the reason why is because it's tied to the CLIA waiver. And so unless your organization has the necessary ability, certification to achieve a CLIA waiver, then a clinician or needs to be involved in administering the Sofia testing. And that's true for all the CLIA waived tests that are out there. At this point, the only thing that is done without a clinician is self collection. Okay, so the saliva test you can collect at home. The swabs that LabCorp and Quest were doing, sending them out for home use, are obviously done by the individual, does not require a clinician, but that's only the collection part of it. The analysis of that sample still happens in a laboratory or still happens by a clinician, and there's no technology at this point that deviates from that standard of having a CLIA waive clinical oversight or participation.
Okay, we're running out of time, but I'm going to ask a couple more testing questions just really quickly, and then just a reminder to everyone that we do answer all questions in writing within a couple days. Are you aware of how many manufacturing/industrial companies are using real-time testing on a daily basis? And when do you see this becoming a commonly used best practice?
Sure. So I'm not aware in total. I haven't seen any studies that have examined workplace utilization of these type of screening tests at this point. Anecdotally, however, we do have clients that are utilizing these methodologies routinely. We know that universities are doing so routinely, as we presented here today, for example, University of Arizona. We know that certain industries, by virtue of either union rules or otherwise, have to perform this type of testing. For example, the media and TV industry that I've mentioned before, we've been helping them for months now, and they have to, by mandate, perform these type of tests on a routine basis, in some cases up to 3 times a week. And so the industries such as manufacturing and other industries are testing. In terms of trying to put a number to it, I'd be kind of shooting in the dark because it's all anecdotal evidence. But I would say at least 5 to 10% of our clients are doing testing routinely for surveillance and or diagnostic testing.
And if the tests aren't being conducted on site, are there centralized locations where one can go in their community to get a rapid test?
Certainly, the answer to that is yes. There are, different community clinical operations that have access to rapid tests. Enumerating those obviously is something that would be on an individual basis. There's no kind of map, if you would, other than what you can find or do through Google, right? Google Maps. If you Google COVID testing, you will get hits, and some of them will provide rapid testing. But in terms of the near site clinics and a list thereof, there's no comprehensive list that we've seen so far.
Okay, and one last quick question. Can you explain why a PCR nasal swab test would produce an inconclusive result?
Sure. So there's a number of reasons why it could be inconclusive. User error could be one, right? In which the sample was just not captured correctly, and the sample did not contain the necessary proteins in the sample to confirm that you're dealing with the right material. And what I mean by that is when you collect a sample for a nasal swab, you're capturing the cells from the mucosa. And those cells have the ability to be detected. The test has the ability to detect whether or not those cells have been adequately collected in the sample, right? And I'm summarizing here and not going into extreme detail. But in short, if the test does not register certain factors in the sample, it will report an inconclusive because the question is, was it an adequate sample or not? Was it a correct sample? There are samples that don't cross certain thresholds in terms of amplification, and that may produce an inconclusive. And then some samples, frankly, get contaminated. And there's a number of, usually that's user error, either in collection or user error at the point of the laboratory. And in those cases, it will report an inconclusive. So it just depends on what happened to that sample as to why that particular sample was inconclusive.
Okay, thanks so much, Dr. Harris. As usual, a very informative session. We'll look forward to seeing everyone back again here next week, and just be safe in the meantime. Thanks again for joining us.
Thanks, everyone. Take care and stay safe. God bless.